Okay, so hello everyone. From now onwards we are going to start Dental Pulse Daily Revise Your MCQ series, जिसमें हम 10 जैसे important MCQs जो previous year MCQs है उसे solve करेंगे और उसे discuss करेंगे along with explanations. So let's get started with pedo first. First, what is the difference between primary and permanent teeth? So, primary teeth have more cervical bulge. Permanent roots are more slender and divergent. Primary enamel is more dense, less enamel dentin ratio of permanent teeth. Okay, so let's look at the options thoroughly. Permanent roots are more slender and divergent. No, this is wrong. Primary enamel is more dense. Wrong. Less enamel dentin ratio of permanent teeth. Wrong. But here the correct answer is primary teeth have more cervical bulge. Now let's look at this teeth, the primary and the permanent ones. Primary teeth has more cervical bulge in compared to permanent teeth. While why primary teeth has more slender and divergent roots? Because of the preceding succedaneous tooth underlying below this tooth. Next is there is a more content of enamel and dentin present within the permanent teeth in comparison to primary teeth. So here as our answer is primary teeth have more cervical bulge. Let's move forward to second question. A mother complains of laceration on the tongue of her 4-week-old child due to tooth in mandibular anterior region. So here the complaint is about the laceration of the tongue. And the options are radiograph to confirm if it is deciduous tooth and sound of the sharp edges, extraction, counsel the mother that this is the main series tooth, prescribe anesthetic gel. अब हम देखेंगे what is natal teeth and neonatal teeth. Natal teeth वो होते हैं जो from birth present होते हैं और ये 30 days after birth से present होते हैं. Mandibular anterior teeth here which causes laceration on the ventral side of the tongue. This disease is known as गाफेरे डिजीज़. अब इस डिजीज़ में लेसरेशंस हो जाते हैं वेंट्रल साइड ऑफ द टंग में. हमें दिया है सेम दैट देयर इज लेसरेशन ऑन द टंग ड्यू टू द मैंडिबुलर एंटीरियर ड्यू टू द टूथ प्रेजेंट इन द मैंडिबुलर एंटीरियर रीजन. So here the answer is take radiograph to confirm if it is deciduous tooth and sound of the sharp edges. Now you will ask that why extraction is not the answer, because here the main complaint is of laceration of the tongue. Also sometimes we go for extraction when we see radiographically there is a lesser tooth structure present in that deciduous tooth which leads to its mobility and can get extruded anytime and can lead to aspiration of the tooth. So in those cases we go for extraction of the teeth. Okay, so but here the answer is option A. Next, frightened 7-year-old with grossly decayed painful primary molar with abscesses and draining sinuses. What is to be done? Option is extraction, assess opening, cleaning, draining and wait for 24 hours to resolve the symptoms, endodontic treatment and obturating with suitable material, and partial pulpectomy and restoration. Now first, here it is given abscess and draining sinus. So it means that this is a case of chronic alveolar abscess. Okay, so here also it is given that the patient is frightened. So extraction will not go for extraction because it is given that patient is frightened. Mostly in those cases where patient is frightened, extraction is avoided at the first visit. So will not go for this answer. Next is assess opening, cleaning, draining and wait for 24 hours to resolve the symptoms. Yes, this is the correct option, because endodontic treatment and obturating with suitable material, we cannot do this on the single go, as we have to give some time to resolve the symptoms. Okay, so here the answer is excess opening, cleaning, draining, and wait for 24 hours to resolve the symptoms. Okay, next. A 7.5-year-old patient presents with unerupted 2-1 and crowding in anteriors. 1-1 is fractured and traumatized 2 months back, which erupted normally at the age of 6.5 years. What should be done? Okay. The option is start orthodontic treatment for 2-1, surgical exclusion of 2-1, place RPD for 2-1, and take radiograph to rule out mesoidens. So here the answer is take the radiograph to rule out mesoidens, because in this case we have to look for the supernumerary tooth, because they are very common at the is at this central incisor area. So first and foremost step for doing any treatment, firstly we have to take the radiograph and rule out all the possible treatment options available, so that it does not get complicated and the treatment does not get complicated. That's why first and foremost take always radiograph to rule out the mesoidens. Next, while doing cavity preparation on a permanent molar, patient has sharp pain which subsides within few seconds. This is the main sharp pain and subsides within few seconds. The treatment plan is: inform the patient about pulp exposure and continue with DCP. Extraction: inform the patient about the pulp exposure and do pulpotomy. Then don't inform the patient about the pulp exposure and continue with the treatment. Firstly, this is not the answer, because you have to always tell the patient about each and every treatment options you are doing and each and every things that you have performed or any mistakes that you have done during the treatment. So option D is absolutely incorrect. Inform the patient about the pulp exposure and do pulpotomy. Extraction: and inform the patient about the pulp exposure and continue with DCP. Here it is given sharp pain and subsides within few seconds, which means this is a case of pulp exposure. Okay, so here we'll go for direct pulp capping. While doing cavity restoration on medial side of the maxillary deciduous canine, which technique is used? Here it is given mesial side of maxillary deciduous canine. So first it is given maxillary. So options are slot preparation, labial lock, lingual lock, or tunnel. So here we cannot go for labial lock, because as it is a maxillary tooth, so aesthetically it will be unpleasant. So we will go for lingual lock. These are the lingual locks which are given in the maxillary anterior teeth. Also, we give labial lock in such situations where we have mandibular tooth, where no more aesthetics are required. So there we give labial lock. Otherwise we give in maxillary teeth lingual lock. Next is avulsed tooth of 3.5-year child should be sprinted for its avulsion. It's a case of avulsion. So what we will go for? The basic is maximum of 2 weeks in the case of avulsion. So here the answer is 7 to 10 days. Next, following image shows IOPA of 1-1 and 2-1 of a child who met with a trauma 3 years before from cricket ball. So here we see the tooth, that is 1-1 and 2-1, and here we can see radiolucency around the between the within the alveolar bones of the adjacent tooth at the cervical area. We see widened canals. See radiolucency at the root apex, and also we see the fracture of the tooth. So this is a classic example of external inflammatory root resorption, because it seems that the teeth has been avulsed and it is placed or reimplanted again in the socket, but this led to external inflammatory root resorption. Radiographically, this is the diagnosis. Characteristic diagnosis is radiolucency at the cervical area of the teeth. So what is the treatment for external inflammatory root resorption? Here the treatment is go for apexification using calcium hydroxide, which will resolve the external inflammatory root resorption. Question 9. All are disadvantages of ZOE except. Main it is given here is except. Options. If pushed periodically cause irritation to tissue. It has poor antimicrobial activity. Rate of resorption is different from tooth. May alter the path of eruption of succedaneous tooth. Now here the option, read all the options carefully. If pushed periodically cause irritation to the tissue. Yes, it is a disadvantage of ZOE. It has a poor antimicrobial activity. No, it has a good antimicrobial property. Rate of resorption is different from tooth. Yes, this is the disadvantage of ZOE. May alter the path of eruption of succedaneous tooth. Yes, this is also a disadvantage of ZOE. So here our answer is, that is rate of, it has a poor antimicrobial activity. So what are the requirements of an ideal root canal filling material? Okay, so ideal root canal filling material should be antibacterial or antimicrobial. Then it should resorb at same time with tooth. Then it should be harmless. Then it should be non-irritable to both the underlying tooth bud which is developing and also to the perioapical tissues surrounding, and it should be easy to apply. Okay, so these are the ideal requirements of a root canal filling material. Next question and last one. A 5-year-old child has deep carious lesion in relation to lower primary first molar. Radiograph shows radiolucency in the periapical area. The most likely treatment is to be: first, observe no treatment, pulpotomy, extraction of the tooth, pulpotomy and stainless steel crown. Now here it is given that it is a 5-year-old child has deep carious lesion in lower primary first molars, and radiolucency is seen in the periapical area. So here the answer is go for pulpectomy and stainless steel crown. Why? Because the child is only 5 years old and there is no unnecessarily requirement of extracting the tooth. And also we have a periapical lesion, so pulpotomy is also not advisable, and also there is an infection, so treatment has to be done. There is no choice of leaving it and observing and doing no treatment. So pulpectomy and stainless steel crown has to be given. Now why it has to be given and why not extraction? Because 5 years is not the age where the underlying premolar which is developing will erupt. It will take time. It requires time. If we extract the tooth, which will lead to malocclusion, so we have to preserve that tooth. So therefore we go for pulpectomy and stainless steel crown. So that's it. We end with this discussion of 10 MCQs which are very important for INI CET and both NEET PG MDS. Thank you.